Hello and welcome to the webinar. My name is Emily Cossack and I'm the Knowledge Manager at the Canadian Institute for Public Safety Research and Treatment. It's my pleasure to be hosting this event made possible by a partnership with the Canadian Institutes of Health Research. Today we continue our series on research done for the post-traumatic stress injuries and public safety personnel Catalyst grants. There are just a few housekeeping notes before we begin the presentation. You're all in listen-only mode. This is to limit ambient noise and feedback during the presentation. Today's session is being recorded and a copy will be sent out to everyone that registered. Some organizations do block the GoToWebinar launch window. This means you may have to join by phone if you're having trouble hearing or viewing the session. Lastly, we ask that you use the questions box throughout the session to submit your questions for the presenters. We'll take time to answer as many as possible at the end of the session. I've also attached handouts for the sessions. In your control panel, you should find 3 handouts. These include the agenda for today and English and French version of the presenter's knowledge translation reports. These handouts will also be posted tomorrow on CIPSART's website, along with a recording of today's session. Now, I'd like to introduce our first project. Project number 1 is Firefighters Accessing Care for Trauma, a clinical case series testing the efficacy of distance-delivered narrative exposure therapy in reducing PTSD symptoms. And our presenters for today are Dr. Janine Olthius, Associate Professor of Psychology at the University of New Brunswick, and Dr. Eliza Kaltenbach, Postdoctoral Fellow. Their knowledge user is Deputy Chief Nina McCarthy. So I'm going to go ahead and turn it over to you guys.
Perfect. Thanks so much, Emily. Maybe you can just give me the heads up that I'm showing the right screen.
Sure. At the moment, I was just seeing your background of a wonderful looking lake that I wish I was on right now.
Yes. Okay. Let's see if this will go up.
Perfect. That's exactly what we want to see.
Okay, great. So I will just start by saying it's great to be here, and we're really excited to share this project with everybody today. So I'm presenting along with Elisa and Deputy Chief Nina McCarthy from Fredericton Fire. So we're going to share some of the audio, I guess, today. We'll share speaking roles, but we're also really here on behalf of a much larger research team that's composed of a bunch of researchers and knowledge users from across Canada. And of course, we're grateful to CIHR for the funding to be able to take on this project. So I won't belabor the point of the motivation for this project too much, because our motivation is really coming from this recognition that firefighters do need increased access to mental health interventions. And I think this is a recognition that most of you share because you're here at this webinar as well. And I think where we got a little bit hung up is we know that, these are high-risk jobs that have a lot of exposure to trauma and result in a higher risk of PTSI, but we do actually have some effective interventions for PTSI-related problems. The problem is that firefighters have some barriers to accessing some of these interventions, and so things like not a lot of practitioners in certain areas, or some stigma-related concerns, or privacy-related concerns. So we've been doing some research in the lab looking at how to deliver interventions over a distance to increase their accessibility and overcome some of these barriers. But one of the things that we realized in doing that is that most of the interventions that we're researching right now are really focused on this idea that people who are doing the intervention have experienced a single trauma, and we know that this is not really a realistic experience for firefighters. Where we're seeing multiple trauma exposure for firefighters. So that brings me to the aims of our study, which we really wanted to develop and test an intervention that addresses this idea that there is multiple traumas that people experience. And so we did this by testing an intervention called narrative exposure therapy, or NET. And Elisa's going to tell you a little bit more about NET in a couple slides. But we wanted to test whether NET could be useful for firefighters with PTSI. We wanted to deliver it by video conferencing to increase accessibility, and we also wanted to have it delivered by a paraprofessional who was supervised by a clinical psychologist, sort of as a way to increase the mental health workforce that could be available to help firefighters with PTSI. So the project was really, this is a very preliminary project. It's really aimed at testing for feasibility. And so what that means is just we're trying to understand, does this work for first responders? Like, is it palatable to them? Is it palatable to firefighters? Are they finding that it's suitable for the types of things they've experienced? Is the number of sessions correct? Do they like the video conferencing setup? Are the paraprofessionals doing a good job? Are there any safety concerns? Those are the kinds of things we were most interested in this kind of small feasibility study. And then we're also looking a little bit at some preliminary efficacy of the intervention as well. So maybe what I'll do first is just turn it over to Elisa, and she can tell you a little bit about narrative exposure therapy itself.
Perfect, thank you, Janine. So narrative exposure therapy, shortly called NET, is a very short-term intervention. And like Janine said, compared to other exposure-based interventions, it does not focus on only one event, but on several ones. The background for that is that we know that people who have experienced more trauma are more likely to experience PTSD as well. So yeah, in firefighters, but also in other groups, we see that we often need to expose more than one event, and that's what we do with NET. And it is a structured exposure of the traumatic events. I'll say a couple of words about that in a minute. It is evidence-based, not with firefighters yet, but we have a lot of studies and RCTs showing that it is very effective in reducing PTSD symptoms, but also other trauma-related symptoms like depression, anxiety, and physiological symptoms. It is also one of the few interventions in trauma therapy that is feasible with paraprofessionals. Has been tested in several countries with paraprofessionals being trained for exactly that intervention. Janine, next slide, please. Perfect. So what did we do in this study? So this study was done online, so that's why we call it eNet instead of NET only. First, we had the consent call, like a preliminary consent call, where the project was introduced, and then there was a survey that the participants filled out, focusing on traumatic events, PTSD, and some comorbid disabilities. And then after that, when they were eligible, they would participate in the full consent call. And then after, we would start the intervention. We had one session of psychoeducation where it's just like a general getting to know each other, getting to know more about the symptoms, about PTSD, and about the intervention and what it actually means in more detail, and what they will be doing. The Lifeline session is very interesting. Like you see the picture on the bottom of this slide is like an example of it, where we try to depict basically the whole life of the client or the participant in showing like good events, but also like traumatic events throughout the lifetime with different symbols. And then the exposure sessions are basically the core of the intervention, where we go step by step through the life of the person, and we try to really focus on the traumatic events, like on the most challenging events in their life, and go in very much detail in them. And then we have a final session where we reflect on the intervention and also give them some tools and discuss some tools about how to deal with new upcoming trauma, especially like firefighters. They will have more traumas in their life if they still work as firefighters. So going into a little bit more detail about what they can do there. The sessions, like we will have around 8 to 12 sessions, and they are pretty long. They are around 90 minutes long. Okay, Janine, now you can go for the next one. Yeah, that's just a short slide basically on how do we do this exposure. And we basically focus on the past event in very much detail, as much as we can get, and we ask a lot for sensational aspects, for cognitions, emotions, physiology, and for the meaning, and we contrast that to the present day, like how they are feeling right now in that day. Okay, and that helps them to process the event and yeah, go through that. Okay.
Great, thanks, Elisa. And so Elisa's done a really great job describing sort of the clinical piece of the intervention. And so just to give you a little bit of research scaffolding here, the first part of the project was really about adapting NET to work for firefighters. And now we're in the middle of the second part of the project, which is that kind of feasibility and efficacy part. So we're doing this as sort of like a clinical case series. We're aiming to recruit 25 firefighters to complete the intervention. Right now we're at 15, so we're doing well. Maybe not as quickly as we would hope, but when is that ever the case with research? So the recruitment strategies, we've used quite a variety in terms of reaching out to fire departments directly, using social media, using the Canadian Association of Fire Chiefs, and also Firewell has been super helpful in terms of helping us with advertisement as well. So Lisa's explained already the details of how we're collecting data, but essentially participants are just completing pre and post questionnaires and doing a short interview as well at the end to let us know sort of what they think about the intervention. And so then maybe I'll let Nina just say a few things, because she was involved in helping to train our paraprofessional coaches in sort of firefighting.
Thanks, Janine. So I was absolutely thrilled when I was asked to participate because what I was able to do was to talk to the coaches around culture. Because the fire service has a truly ingrained culture. There is still stigmas in terms of mental wellness, mental health. There's still this idea that outsiders perhaps aren't trusted. And also, you know, that part about access is very real. Firefighters typically, by the time they actually go to get help, it's typically because they haven't had any small interventions on the way. They waited till it was, you know, at a point where they had to seek help, and help isn't necessarily available. Being here in New Brunswick, you know, there are limited providers, and we see this being a way for our people to gain access. You know, the fact that this is done electronically, the fact that it can be done in a format that it truly is accessible. So again, I was thrilled, and being able to talk about the barriers to success for an intervention within the fire service will hopefully allow the program to move forward and overcome those barriers. Without that dialogue, I'm not entirely sure that the team would have known that there were those obstacles present. So thanks again for the chance to participate.
Thanks so much, Nina. And Elisa, maybe just 30 seconds about supervision and training.
Sure. Yeah, it was great having Nina, and it was a very important part of our training. In total, we had 3 weeks of very intense training full time because we worked with paraprofessionals and we wanted to make sure that they're properly trained. And a lot of it was like role plays and like practicing the intervention, and also like basically processing their own trauma in order to be like able to like do a good job in going through the traumas with the firefighters. Right now we have weekly group supervisions, we have bi-weekly individual supervisions, and we got a peer support system which works pretty well too. And we reviewed the video calls. We have like a randomized part of them for quality assurance.
Okay, so we'll finish here by showing you some very preliminary results. And I say very preliminary because it's so few people that you really shouldn't extrapolate from here, but we can kind of look at trends and see if things are moving in the right direction. So here what we have is the GAD-7 is a measure of anxiety, PHQ-9 is a measure of depression, and the PCL-5 is a measure of PTSI symptoms. So the red bars are their scores before the intervention, the black bars are their scores after the intervention. So generally what we're seeing is some movement in the right direction. But like I said, this is preliminary. It's enough to give us hope that we're like doing something that could potentially be helpful, but we need to do a bigger study after this. And that's where the kind of feasibility part comes in and what we're really taking away from this study. So feasibility analyses have given us some ideas about good parts and some things that we need to change. So one of the things that's really clear is that we need to do a little bit more work around recruitment strategies, because we know there's a need, but we feel like we're not necessarily tapping that need necessarily. So that's one of the things that we'll continue to work on. Overall, there's some nice satisfaction ratings from the participants who have engaged in the intervention. Some suggestions that perhaps the sessions are long, so they're 90-minute sessions, and for a lot of firefighters with families and lots of things on the go, that can be a little bit long. So that's something that we'll think about from a feasibility perspective. Definitely a mix. Some people really like the convenience of online. Some people really feel like they would prefer it to be in person, but generally the feeling is I'd rather have it online than not have the intervention. So that's kind of, I think, where we're at in many cases. And then one of the most important pieces for us was really testing to make sure that the paraprofessional delivery would be okay, because I think that's where we were getting the most hesitance from people. But resoundingly, the participants have been really supportive of the value and importance of those paraprofessional coaches. No concerns about safety have been raised. They've really said that they couldn't have done this without the paraprofessionals, and have appreciated their efforts to sort of understand firefighting culture, even though they recognize that some people have said it would be nice if it was a peer who kind of had already had experience like them as well. And the last thing I'll say about feasibility is we've had quite a range in terms of, what has the impact been on your life, where some people are saying, well, I don't think I was too bad to start with, so I don't know that this changed my life too much, to other people saying I was able to go back to work and I didn't anticipate that. So there's quite a lot of variability in outcomes. So right where we are right now, we have some good feasibility data, some good signs of promising efficacy, but we need to really finish this pilot. So we've got 10 more participants to recruit. So this is maybe a plug to spread the word if you know people who might be suitable. And then from there, we'll be able to use this data to inform a larger study to test this kind of more broadly across Canada. Yeah. And I think I'm cognizant of the time, so I think I'm going to end there, Emily, and pass it on to the next group so they have enough time to present as well.
All right, perfect. Thank you so much. Great presentation. So I'm going to take back the presenter control here, and thank you guys. We'll welcome you back when we have questions later. So I am going to go ahead and show here for presentation number 2. So project number 2 today is a smartphone ecological momentary assessment app for collecting real-time data on post-traumatic stress injuries in firefighters. It is going to be presented by Dr. Stephane Guay, and his knowledge user is Michel Amesse. And I'm actually going to be presenting their slides, so you're going to just bear with me for 1 second as I switch over and show the right slides. And everybody can see that. Is that okay? Okay, so I am going to disappear, but I will be here, and you can just let me know when you need me to change the slide.
Perfect. Thank you, Emily. It's a pleasure to be here today with you. I want to thank Michel also to be with me as a presenter today. So Michel, of course, is represented Montreal Fire Department. Who is a great collaborator in the project, and at first the first slides of the presentation will be presented by Michel, in which we will describe the Montreal Fire Department, its breadth, and also the more specificities about the first respondents within the group of firefighters that we are studying. After that, I will, of course, show you some on our side, or also a very preliminary result of the project, and then we'll go on. So, Emily, next slide, please.
Well, thank you very much for the opportunity that's provided to the City of Montreal Fire Department to collaborate with the people from the Centre d'études sur le trauma, our trauma research partners. Are providing an opportunity for us to be at the forefront of mental wellness and break down the barriers that are often perceived with first responders, mental health issues, and their obvious need for treatment. It's an honor for me to be able to present the functioning and the overall structure of the City of Montreal Fire Department. Well, first of all, we protect over 2 million citizens. Our daytime population swells to well over that. We cover an area. Montreal is an island. surrounded by water. It covers approximately 500 square kilometers. Of that, we have 266 kilometers of shoreline, over 400,000 residential structures, commercials, and institutional buildings. We run out of 66 career fire stations with an additional career station that's seasoned during the summer months. We have on duty, we have 2,350 uniformed personnel, of which 1,725 are certified first responders. You can provide the next slide, Emily. We have a staffing of 70 engine companies. When all our units are in service, we have over 70 engine companies who are staffed by 2 certified first responders. We have 51 ladder companies, 8 manpower squads, 3 technical rescue units. We have a combined hazardous materials response team from Station 29 and 65. We have 8 certified water rescue teams and 5 certified ice rescue teams as well. An overview of our great city with our multiple stations. Next slide. We just have preliminary, very schematic breakdown of our number of total responses within the past 5 years. Obviously, 2020 took a significant hit in the number of responses due to the COVID situation, but we average approximately 125,000 overall responses. Of those, year after year, over 45,000 or so of those are fire-related responses, be it automatic alarms or assistance, car accidents or whatever, and over 80,000 EMS responses annually, for a gross average of approximately 125,000 responses for the fire department yearly.
Well, thank you, Michel. So it shows of course, the amount of exposure that these first responders are exposed to during the year. And so our collaboration with the Montreal Fire Department started in 2017, and we were asked as the Trauma Study Center of the University of Montreal to conduct a survey among their members and to evaluate PTSI and to see what were the problems that were present and how much they were present as well. So we recruited a sample of over 500 firefighter and first responders, and we selected from the stations that had the highest number of intervention per year. Next slide, Emily. So following this survey, we found out that over 5% have the score suggesting that they had an anxiety problem. 31% presented a level of intensity of symptoms of depression that suggested that they could be diagnosed with a depression, and 5.6% presented with a score suggesting a PTSD. So overall, about a third of the participants presented at least one of these disorders, and this is why we were interested in continuing this collaboration. We also, with this survey, we identified several variables that were associated with the presence of one or the other disorders. So number of years of experience, age of participants, number of years in the fire department, as well as the number of critical incidents that were reported in the year prior to the survey. Next slide. So the current project aims to evaluate continuously over 12 weeks the variation in PTSI among a sample of the Montreal Fire Department, especially among first responders who have been exposed to a potentially traumatic event within the past 6 months. We wanted to test also the feasibility to use a smartphone app to collect the data, and as well as to measure, in addition to PTSI symptoms, some predictor risk and protective factors that could relate and explain the fluctuation in PTSI intensity over 12 weeks. In addition, we added a measure of well-being, and that was also assessed more frequently. Next slide. So basically, I have already done that. So next slide, Emily. So we used an app that was developed for research purposes, and it's based in Canada, and so we could program this app to and include, just like let's say a SurveyMonkey would do, the questions that we wanted the participants to answer, and it was available both on iOS and Android phones. Next slide. So these are the socio-demographic of the participants. As you can see, we have a nice variation in terms of years of experience, as well as of total age of participants. Next slide. So the study included three parts, three steps. First step was to do a pre-assessment of the portrait of the clinical problems that were presented with a semi-structured clinical interview, called the MINI. And we also, after that, the second step consisted of delivering the mobile application to each participant, and to measure both PTSI and risk and protective factors, as well as well-being, over a course of 12 weeks, as I mentioned. And then we run also post-test interviews. Next slide. So this illustrates how it's being done, and these are the data that we will present today. So we selected the subsample of 52 participants in the study, and that have responded to the 4 waves of measurement in the study so far. And so, as you can see, we alternated between risk and protective factors on 1 week, and we measured the PTSI symptoms the other week, and then and so on and so on. So, but the well-being question was asked 3 times a week, so that we could see how well-being is either independent or fluctuate independently with PTSI symptoms. Next slide. So far we have recruited 191. So it was up to the January the 31st. Now we're already at 260 participants recruited. So we're almost we have almost reached our objective of 300 participants. Next slide. Next slide. So with the MINI, we could evaluate the presence of different disorders prior to the participation in the study. So we had a level of PTSD, diagnosable PTSD presence of 10%, 8% for depression, and 12% for panic disorder, which in the literature is the most prevalent anxiety disorder. So that's why we measured this one. So next slide, Emily. To measure the PTSI depression symptoms, we used the PHQ-9, which is a well-known questionnaire. We used a cutoff point of 5 to include people who were presenting mild level of intensity of symptoms. So that could be also comparable to what we found, what we used in the survey in 2018. Next slide. what we found was that here is that overall we had the mean scores of around 3, but overall we found that 32% of between 23 and 32% of participants presented a level of mild to severe depression, mostly mild depression, of course, when we look at the average score over the 3 waves of data, so being the pre-test and 2 subsequent waves during the 12-week process. Next slide. With regard to anxiety, we used the GAD-7. Again, we used a cutoff of 5 to identify those who were presenting a minimal level of anxiety and to be able to compare to the survey in 2018. Next slide. Here we found that the level of anxiety was higher than what we found in the survey. Between 25 and 37%, according to the wave of data, were presenting mild to severe level of anxiety. Again, mostly mild level because of the, as you can see, the mean scores that are reported in the bars. Next slide. For the post-traumatic stress, we used the PCL5, the 8-item version. We used the cutoff score of 13, suggesting more the presence of almost clinical levels symptoms of PTSD, because there was not other cutoff scores that we could use for mild levels. So next slide. Here we found that between mostly around 2% presented a clinical level of PTSD symptoms at each waves of data collection. Next slide. So with regard to protective and risk factors, of course, social support being a protective factor, we use the Oslo 3-item social support scale. That asked 3 questions about social support. Next slide. And we found here that, between 30 and 45% reported a very high level of social support at each wave of data collection. But we also found that it could become also a risk factor. Of course, a lack of social support is very well known as to being a risk factor, and we found that here that between 12 and 21% of participants reported a very poor level of social support. So we will explore how it plays a role of protection versus risk. Next slide. We also, the last risk factor that we measured and that we'll present to you today is the brief codes, the tendency to self-blame in reaction to stressful situations. Next slide. And we did find that, again, there's like a moderate level of self-blame, but as we can see, the mean score is around the half capacity of the total score of the scale. So it gives us a lot of variance that will also give us the possibility to run analysis and maybe found correlations with the PTSI once we have more participants in the study. Next slide. Finally, with regard to well-being, it was the question that was asked 3 times a week was reflecting on your own life and your personal situation. How satisfied are you with your life in general? And so people had to move the cursor to indicate from 0 to 100 the level of satisfaction that they had presented. So we can see here that it's really in the upper range of the scale that we found the total score. So ranging from 75 to about 82. So it's quite a nice, very high level of satisfaction and well-being. So, but again, I think that we'll have enough variation eventually to find exciting results with regard to well-being. Next slide. So in summary, our preliminary results are similar to the ones obtained in the 2018 survey for the prevalence of depression and PTSD. However, we did find higher level of anxiety than in 2018. Of course, we can relate that to the pandemic for sure, but we'll see eventually with our results if there are other factors involved in this increased level of anxiety. Our very preliminary results suggest that among these firefighters, first responders, 12 to 21% have poor social support, and that they tend moderately to use self-blame as a coping strategy. And our next step, of course, will be to finalize the recruitment. Oops, can you come back? Thank you. To analyze data, said that this will be an exciting step, since we'll have a lot of waves of data to correlate with the risk and protective factors, and as well as the socio-demographic variables that we have identified as potentially related in the prior survey. We will plan, of course, a knowledge transfer and prepare a grant proposal for a phase 2 using the results in the current study to feed maybe a new tool for self-management of PTSI among firefighters and first responders. Thank you.
All right, thank you so much for your presentation and for putting up with my changing of your slides. So I would like to welcome our third group to the presentation at the moment. So the third project for today is a cross-jurisdictional and contextual evaluations of mental health resiliency training in firefighters. It is going to be presented by Dr. Joy MacDermid, and her knowledge user is Captain Steve Fraser. And Joy, I am just going to go ahead and give you the presenter control. There we go.
Can everyone see that okay?
Yeah, it looks good.
Okay, great, thank you. Well, welcome everybody, and a welcome from both myself. I'm Joy MacDermid, and I'm joined by Captain Steve Fraser, and we're going to be talking about our project on mental health resiliency. And the first thing I'm going to do is transfer over to Captain Fraser to explain to you what Resilient Minds is.
Hi, good morning, and thank you, Joy. Resilient Minds was created by Vancouver Fire in partnership with Canadian Mental Health Association. We started working on it in sort of late 2015, early 2016, and really it was a program that was developed to deliver to our firefighters here in Vancouver on recognizing when you're struggling, recognizing when your peers are struggling, and being able to take action and do something about that. That's sort of how it originated, and it did just start with Vancouver Fire, and then quickly started to spread out to some other local fire departments within British Columbia as well.
Great. So now I'm going to talk about the research project that we did, and our research objectives were really to explore how implementation of a program like Resilient Minds works in different fire services. In particular, we were comparing Vancouver and PEI, and we wanted to find out some things about how the program worked and what helps or hinders moving these good ideas into practice. So it was about implementation science. So just to give you a quick illustration of how different these two sites were, not only do they exist on different ends of the country, but Vancouver was, as Captain Fraser mentioned, the development site. It's much more urban, mostly career firefighters, not totally. And they're much more mature in their process of dealing with mental health issues in terms of they had been involved in this for a while. Contrasting this with PEI, which has a number of small volunteer fire departments, there had been no prior resiliency training. There's one career firefighter in all of PEI at the last we counted, and the rest are all volunteers, a much more rural setting, and there had been little programming in place around mental health. So our research approach was both the qualitative and quantitative methods. In this presentation, we are talking about the qualitative results. We interviewed people before and after the program. We did surveys pre, post, and after they had been able to have time to implement the training in practice, and we used standardized measures of mental health. So the interviews were conducted with peer trainers, firefighters, and chiefs, and we did interviews, the numbers are here, in both locations of all three types of people involved in the program. And we used in these interviews, we explored their experiences with program implementation, what some of the organizational or individual barriers and facilitators were, some of what they thought were the salient components and the impact of the program, and how the program might be optimized in the future. So first, I'm going to present what the themes were in our findings from both sites. These were things that both sites agreed upon. And on the right here, we have Dr. Amanda Brazil, who was involved in providing the training, who was both a volunteer firefighter and a PhD candidate at the time. And so both sites agreed that Resilient Minds was very useful in terms of improving awareness of mental health, reducing stigma, improving communication amongst the team, and coping skills. Everyone agreed that the firefighter peer trainer was critical to success of the program, that chief and senior firefighters were really important in terms of leadership, and that their leadership was really important to the success of implementation. Some people admitted being skeptical about the training, but afterwards being very glad that they did it. There were some really common gaps or needs identified. These included family training, refresher courses, and the availability of treatment in the community. So many people spoke about, now I know that I need some help, but there's no help there for me. And a lot of people talked about the cup analogy, that they now understand that stress is cumulative and that things build up. Some of the implementation scale-up issues that we identified is that it takes considerable time and effort to develop the resources and the pool of trainers to deliver the program. Although everyone agrees that it's important to have evidence to show whether programs work or not, there's great difficulty in getting people to complete outcome measures consistently. So everyone enjoys participating in the program, not so much filling out the outcome measures. And the champions are really critical to move things forward. And I certainly know that all the success of this program hinges largely on the support of Captain Fraser and Dr. Amanda Brazil to implement these at these two sites. So now I'll go through some of the things that were a little bit different between the two sites, and some of the things that we found that were variations between Vancouver and PEI. So Vancouver talked a lot more about the program helping them to be open and talking about mental health and to recognize the signs and symptoms in others. Whereas in PEI, they talked about a lot more about how they learned about coping and stress management, and there was a lot more about their own self-awareness. In terms of what people talked about being valued in the training, in Vancouver, it was already mandatory, so they appreciated that, but they also talked a lot more about, I don't want this to be just a checkbox that everybody has to do. I want this to be real, and I want it to be considerable. And in PEI, there was no services, so there was much more focus on, we would like this to be mandatory, and we want to receive training, and we don't have access to it. In terms of priorities, Vancouver people, the firefighters talked about, they recognized that mental health is a major priority and that mandatory training was important, and everyone agreed that it was important. In PEI, there was a lot more recognition of, yes, it's important, but we also have a lot of other competing training needs that are not being met at the moment too. So how do we prioritize all of these competing needs, especially since we are volunteers and we have other jobs and roles that we have to perform? In Vancouver, the delivery format that worked the best was having a condensed 2-day back-to-back format. This worked best for scheduling and shifts, whereas PEI, the program was adapted into different modules, and those modules were delivered over a much longer period of time to spread it out in recognition of the time commitments that the volunteers had. When we asked people, what new coping strategies have you implemented because of Resilient Minds? In Vancouver, there was a lot of talk about self-care and coping mechanisms. People started to do things they hadn't done before, like yoga, meditation, and exercise to focus on their mental health. Whereas in PEI, there was more emphasis on, now we talk about mental health and what happened on calls. Now we ask people if they're okay. And these were new things that weren't being done before, whereas there was more of a sense that that was already happening in Vancouver. Some of the changes that people talked about implementing at work because of resiliency training was that they took the skills that they learned during the resiliency training and applied it to their daily work. They used the resources that were available, and they used the coping strategies. Whereas in PEI, they talked a lot about recognizing the signs both in themselves and others, and a lot more recognition of what mental health problems and challenges start to look like in others. In terms of the impact of Resilient Minds at an organizational level, in Vancouver, there was a lot of talk about, we already were dealing with the issues of stigma, and we had some coping strategies, but this really reinforced what we were doing. We were already doing debriefing, but we did still improve our practices in terms of our coping strategies and debriefing after participating in the program. Whereas in PEI, there was a lot of recognition that there is stigma around mental health. There's fear of being seen as being weak if you have a mental health problem. There's a lack of awareness of what mental health looks like, and people just tended not to talk after a call. And after attending the resiliency training, they talked about being much more open about talking about mental health and more comfortable talking to their peers about it. There was less stigma, and they had instituted a policy, not a policy, but a practice of talking about things after every call. One of the interesting findings between the two sites was in Vancouver, the issue about comprehension of the materials. You know, some of these materials are reading and require reflection. That had never come up as a problem in Vancouver. In fact, there was some people talked about appreciating complex topics like learning about physiology and how the brain works. In contrast, in PEI, there were times where literacy did become an issue. The readability grade of the content needed to be adjusted in some cases. Some of the concepts that were more complex and that required writing and reflection had to be adapted a little bit, and some of the content was seen as being hard by some people. And this was because we found in some of the rural communities there was mixed literacy levels. Some of the implementation barriers talked about in Vancouver were the logistics and scheduling issues about how do you schedule teams and firefighters to come to the training, and what do you do if a firefighter misses a module or something comes up on their days off. So it was a lot about the scheduling and how it fits into the service scheduling. Whereas in PEI, the implementation barriers were a lot more about the costs of the program. Is there any funding for this? And their lack of availability of facilitators and trainers. Just to give an illustration of how research can support implementation, some of the things that happened because of this grant were, first of all, Dr. Amanda Brazil did some of this work as her PhD work and was successful in defending that. We strengthened our partnership with the Canadian Mental Health Association. The program was adapted and the resources were adapted by Dr. Brazil in order to be more appropriate for the volunteer context. We developed a shareable online database so we can have people fill out the outcome measures online, and we are happy to share that with any other group that's implementing the training that wants to use that database to track their responses. And we also developed a website to support the trainers and trainee, and here's the website recently launched that has a number of resources to facilitate the training. So the grant funds were used to support trainers, to support databases and website development that contributed to part of a national launch that was recently announced. So our conclusions were that great programs must adapt to local context and to pandemics, and that Resilient Minds was valued into very diverse firefighter contexts with adaptations needed to fit the context. I'd like to thank all the collaborators, partners, and sponsors who really made this work possible. A large number of firefighters participated in training, and it wouldn't be without the collaboration of all of the people listed on this slide for that to happen. And I wanted to just transfer it back to Captain Fraser. He can give you an update about where Resilient Minds is now in terms of responding to the pandemic and some of the current challenges.
Yeah, thanks, Joy. So obviously some of the challenges are how do we deliver this training now with other departments virtually? And so we really stepped up to that challenge, and we spent considerable amount of time adapting this program so it can be delivered virtually as well. Just recently in the October, November of last year, we did train some national trainers, both CMHA and firefighters across Canada. And that was our first sort of national or first training that we did virtually. We have since also delivered in this course to a couple of fire departments virtually, both locally here in British Columbia and also throughout Canada as well. So it's working well. It's been a real challenge, but we're still able to get it out, and we're still able to educate our firefighters and help our firefighters. So it's been a really interesting year with all that. Thanks, Joy.
All right, thank you both for that wonderful insight on your project. It sounds like a really great project and is really bringing benefit for firefighters especially. So I am just going to welcome back some of the other project presenters as well. We are going to do a few questions. If anybody has questions that they haven't asked already, please feel free to send them in now. I do have one for the first project team. There was a question of if you will be able to compare the eNet data, so the project you're doing, to the in-person net, if there's enough data out there for you to be able to compare the two from an effectiveness level.
Good question. So I guess the answer is two-pronged. One is this hasn't really been done with firefighters before, so we don't have in-person firefighter data that we could compare it to. We can look at how it compares to in-person net that's been done with other populations, but those other populations, though similar in that they're experiencing multiple traumas, tend to be things like refugee groups, those kinds of things. So it's a little bit different perhaps than firefighters. So I think a direct comparison probably won't be possible, but we can certainly see if we're seeing similar like efficacy or effect sizes as we were with as the other groups have been with the other populations.
Okay. So for project number 2, was all of your recruitment done during COVID, or was any of it done pre-COVID?
It's all done during COVID. We started in at the end of October, and we'll probably end up in a few weeks. So it's all in COVID.
Okay. And project number 3. So Resilient Minds has been developed for firefighters. Is it a program that you think could extend to other public safety personnel, or is it really designed for firefighters specifically?
Yep, no, it was designed for firefighters because I'm a firefighter, but it certainly can be adapted and modified for all public safety personnel. We've been working with Wildfire Fire Service out here in British Columbia and doing some significant work with them to adapt it for their needs as well. So, and not just career firefighters, that was the work that we did with Amanda, with Dr. Brazil, to make sure that we have it's relatable to volunteers. As we know, volunteers make up the majority of our firefighters within this country, and we need to make sure that we're looking after them as well. So we've definitely been able to make the adaptations for other agencies and other groups.
Okay. Project 1, do you find that COVID has actually removed the barrier of people not liking the online as much, or has it not changed it at all?
I would say it hasn't changed it too much because people are more receptive to using online methods, but they're still they can still appreciate that they would prefer that the barrier wasn't there so that they could be in the room with someone. I think the most kind of feedback we've got is, you know, this is an intervention that generates a lot of emotion, and it's one thing to be kind of crying on the other side of a computer screen with someone. It's something different to be in a room with someone experiencing that kind of emotion. And I think that is accurate. You can't necessarily capture that. So like I said, though, people are happy to do this now online because that's what's available. And they know that COVID is like creating increased barriers to doing it in person. And I think they recognize that, you know, we're focusing on participants in Atlantic Canada quite a bit, and there are more limited resources in those areas, like just hearing about Joy and Steve talk about PEI, for example. They've been really happy to be able to participate in this intervention too from that location.
Project number 3, you talked about offering virtual delivery now. How has virtual delivery been received compared with the in-person delivery that you did prior to the pandemic?
Actually really well. It's been received great. I think people are getting more and more used to it. There's also, I mean, the course is not intended to be therapy. It is, that's not what it's for. It's meant to be psychoeducation, but yet there's components that that can bring some things up for anybody. And I think there's some comfort that people had about just being at home and being able to explore this a little bit and talk with their family members, and you know, after taking the program. So it's actually surprisingly, it's gone really well. I love teaching, I love presenting, I love doing it in person, but yeah, it's gone remarkably well doing this virtually. So yeah.
Wonderful. Project number 2, is it possible to gamify or incentivize firefighters to use your project so that you can get more information from them?
Yes, of course. The app that we're using is quite basic, but it does the job though. But it's quite basic, and I think in the future, if we want to use this this kind of device to continuously assess the level of symptoms of PTSI among the firefighters, we will need an app that is more that has a better design actually attached to it, and maybe also some incentives method to have them you know, to have more fun using it, so it can be more a friendly user. Absolutely, but this will be a next step.
All right, perfect. So that does look like that's all the questions we have for today. So I want to thank everybody for all of our presenters and all of our knowledge users for being here with us today and sharing such valuable information with us. And I want to thank all of the people in the audience for coming today and asking questions and participating. As we reach the end of our session, we want to ask you to complete the survey that will appear after the end of the session. Feedback from you is important. Tomorrow, you'll receive an email that'll have a video of today's session. On February 23rd, CIHR will be hosting a session on PSPNet, which is the Internet-Delivered Cognitive Behavioral Therapy for Public Safety Personnel. We hope you'll join us to learn more about this effective free program. We'll also be concluding the post-traumatic stress injury series on February the 25th. If you haven't signed up already, the link will be available on our website, and it'll be in the follow-up email tomorrow. To everybody out there, please take care and stay safe. And if you are in the West, please stay warm. All right, bye everybody.
Bye-bye.
Thanks, everyone.